Good morning, good afternoon, good evening. So welcome to the NTB Roundtable Session 1. The Union, along with Central TB Division, Ministry of Health and Family Welfare India, is planning NTB Roundtable as a regular monthly sessions to discuss various thematic areas related to TB. Today's session is organized by USAID-funded, Union-led iDefeat TB project, along with the consortium partner KNCV TB Foundation. This will act as a knowledge sharing platform. We have all the participants across the India and from abroad joined for this NTB roundtable. Today, we'll be discussing experiences of BPaL related regimen rollout. I request Dr. K.S. Sachdeva, the Regional Director of Union Southeast Asia, to offer welcome to all the participants.
Thanks, Rakesh. All the esteemed participants of this workshop. This being an international workshop, I again say yes, good morning, good afternoon, good evening, whichever part of the world you are. We at India USAID office have been implementing a project called iDefeat TB on behalf of USAID and supporting the Ministry of Health Central TB Division, Government of India on various aspects of institutional strengthening, including the rollout of BPaL regimen. So special mention about dignitaries who will be addressing today are Professor Guy Marks, Dr. Joshi, Dr. Ruben, Dr. Agnes, Dr. Beckett, Dr. Mamel, Dr. Shivani, Dr. Foreda, Dr. Fraser, Dr. Malik, and Dr. Ravinder. So welcome to this first this newer regimen. We thought it will be best to share experiences from across the globe on how best we should pick it up. Also, we at USC office thought that why not introduce a monthly roundtable discussion on topics of common interest and which are important currently for the keeping the NTB epidemic in mind. So with this, we said, okay, let's start with the BPaL regimen. A lot of speakers who will address you after me will talk about this regimen. So I'll restrain myself on the specifics of this regimen, but welcome you all to this NTB roundtable and look forward to a very fruitful deliberation. Over to you, Rakesh.
Thank you, sir. So I request Dr. Agnes Jabbar, the Director TB and HIS from KNCV, for the opening remarks.
I'm trying to open my video, but I cannot open it. Okay, I do.
We can hear you, Agnes.
Okay,
nice.
I'm here.
Now we can see you.
Yeah, thank you very much. Okay. Yeah, so I'm Agnes Gebhardt, Technical Director of KNCV TB Foundation. And we at KNCV, we respectfully agree to all participants and thank you, Dr. Sachdeva and the organizers for the opportunity to address this audience. In general, KNCV supports national TB programs and their partners in the strengthening of health systems by developing and implementation of country-specific patient-centered policy and technological innovations, paying specific attention to children and vulnerable people. And in India, in the framework of the iDefeat project, KNCV specifically supports strengthening the capacity of the NTP to respond to the challenges posed by drug-resistant TB. We do this, of course, together with the Union and the partners funded through the USAID mission. This included building resilience into the systems for rapid evaluation and uptake of innovations, like the introduction of novel, shorter and better treatment regimens, and the changes in diagnostics algorithms which come with it. So we are living in exciting times, and with the new WHO DRTB treatment regimens to be published in 2022, most risk-resistant TB patients will be able to benefit from fully oral BPaL containing regimens of only 6 months duration, which of course is a large improvement compared to the current regimens. Of course, a minority of patients would still need the 9-month regimen, like children under the age of 15 and pregnant women. And some people would still need longer individualized DRTB regimens, especially those with additional resistance to beta-choline, predominate, and linezolid. These would typically be patients who failed earlier modern treatment regimens. In this meeting, we shall share the information on the rapid communication of WHO on the new regimens, and we will share some experience KNCV gained in the Philippines and Kyrgyzstan implementing the COICA-funded Live2B project with the TB Alliance and ITRC. And the TB Alliance will share information will share their experience of the implementation of BPaL in the clinical trials. So the transition for the BPaL-based regimens will need careful planning. It will mean phasing in the new regimen and phasing out or reducing the longer treatment regimens, adjusting ADSM systems to capture and monitor the relevant adverse events, assuring access to the relevant laboratory tests, and paying attention to psychological, social, and economic support and adherence support for patients and their families. So we wish you a successful meeting and stand ready to work shoulder to shoulder with you to support India in uptake of these new regimens. Thank you very much.
Thank you, Dr. Agnes. May I request Dr. Ruben Swamikan, the Chief of TB and Infectious Diseases, USAID India, for his opening remarks.
Thank you, Dr. Rakesh, and good afternoon to all of you all from India, and good day for the others from the other parts of the world. It's good to see that there are almost 200 people who have joined. I'd like to take this opportunity to thank the Central TB Division, Ministry of Health and Family Welfare, Government of India, for showing leadership and taking this initiative forward, especially to understand the experience on the rollout of shorter or oral regimen with newer and fewer drugs for treatment of DRTB. And so this is, I think, really going to share with the world the successes that have happened in India, and of course the challenges that other countries may not need to replicate. This group of experts who are meeting here today fully realize the disproportionate gaps that exist in MDR-TB care, and we generally detect a lesser proportion of estimated MDR-TB cases, and even lesser proportion of those who are diagnosed are treated successfully in comparison to drug-sensitive TB. All of this in the same programmatic setting. So obviously something's off, and I think this bringing together of experts should help throw more light on how we can move this forward. Now, although the estimated number of MDR-TB patients looks smaller in comparison to the overall TB patient, it requires special attention for a number of reasons. Firstly, the potential threat of MDR-TB patients and the proportion of drug resistance is rising, and it will continue to rise if not adequately addressed. So I think that's the first thing that we need to look at. Secondly, MDR-TB requires additional steps and tests for diagnosis. If patients are not closely followed up in the diagnostic care cascade, they're at the risk of being lost to the system. So the challenges are multifold. It's unlike drug-sensitive TB. And thirdly, DRTB requires more tests, more drugs, more follow-up, more time, and more resources. And all of this can be a challenge. So, I think it's for the experts within the global community to understand how all of this can be addressed, to be able to ensure that to address this serious issue. It's heartening to see the efforts of the researchers and the program managers in the world looking for options to address these challenges, especially things like rapid tests, extended drug susceptibility tests, to help clinicians decide on an appropriate treatment regimen earlier in the course of disease and not later that we've been seeing in the past. Also looking for newer drugs and new approaches to complete the diagnostic workup in a quicker and shorter turnaround time, which will really be useful. And of course, injectables, and is it something that we need to definitely ensure that it moves out of the regimens, and also look at reducing the number of pills that the patient needs to take. So I think there are a number of challenges, and it'll be wonderful to understand the experiences from around the world for the clinicians who are treating TB patients to be able to understand what's the best that they can provide to their patients. So I'll stop here. I'll wish everyone success and thank you for having us on board. It's an absolute pleasure. Thank you.
Thank you, Dr. Ruben. So we have Dr. Rajendra P. Joshi, the Deputy Director General of TB, Ministry of Health and Family Welfare, India, with us. I request Dr. Rajendra P. Joshi for the opening remarks.
Thank you, Rakesh. Good afternoon, all. Greetings from India. Right now, I'm traveling, so please excuse me. My apologies if the internet connection is not very clear. Firstly, I thank the organizers for giving me this great opportunity to learn from all experts here about the regimen. India has got one of the major issues. Achieving elimination of tuberculosis by 2020. Drug-resistant TB is one of the very, very important components, which is very vital to achieve goals. So, in recent years, we have got newer medicines, and we have moved from injectables and longer regimens, multiple drugs, to much shorter regimens and oral drugs. Already moved to all oral regimens. Now, none of my patients are going to be started on injectables. But that said and done, there are multiple other challenges in MDR TB, right from adherence, right from managing the side effects, and of course, drug resistance itself. So I am sure the newer regimens, which are of shorter duration and all oral, will make a huge impact on this adherence part and also on managing the patients. So I'm looking forward to learning from the experience of other countries and wish this roundtable all the success. Thank you. Over to you, Rakesh.
Thank you, sir. Now we have Professor Guy Marks with us. He's the professor at the University of New South Wales and the president of the union. I request Dr. Guy Marks to deliver his special address.
My address is going to last for 2 minutes. So.
Professor Guy, you are on mute.
Now I'm unmuted. Yes. Thank you very much for inviting me to say a few words here. And I want to, first of all, welcome all of the participants. It's wonderful to see. I think we now have 240 people attending. I want to pay my respects and greet representatives from KNCV, from USAID, from WHO, and from the Government of India and the Ministry of Health and Family Welfare, and from many other organisations that are present here today. Thank you very much for joining us. I want to also pay tribute to Dr. Kuldeep Sachdeva, who's the head of the Union Southeast Asia, for his leadership and for his bringing together this NTB roundtable. This is the first of several roundtables that he's proposing to hold. I think it's an excellent initiative and a good start to focus on drug-resistant TB. Drug-resistant TB has been, since the 1990s, really a major threat to global TB control, in large part due to our failure to adequately deal with it in previous years. And the changes in management of drug-resistant TB that have become available over the last 3 or 4 years are truly revolutionary. And as somebody who's been dealing with this disease, and many of you as well, to be able to consider treating patients in 6 to 9 months when we were not only very recently requiring 18 to 24 months of treatment is extraordinary, and with effective and largely safe regimens. I want to take this opportunity also congratulating the TB Alliance on their leadership in bringing about this BPaL regimen and seeing it through to this point. I think it's been a great initiative and a great achievement. I would just say that there of course are other, there is more data to come, and you probably know that the STREAM trial, the STREAM 2 trial, will be reporting. Many of you will know that the STREAM 2 trial will be reporting its results later this year. And we're all very excited about that. And I think that will add additional options to us and additional information that will assist us. But in the meantime, the BPaL regimen is a great breakthrough and has led to major innovation and improvement in outcomes for patients with drug-resistant TB. And I greatly look forward to hearing from our colleagues in Kyrgyzstan and in the Philippines about their early experience with this regimen. So thank you very, very much, and thank you for giving me the opportunity to speak.
Thank you, Professor Marx. So now may I request Dr. Mansa from KNCV to further moderate the sessions and take the academic session forward. Over to you, Dr. Mansa.
Yeah, thank you very much, Dr. Rakesh, and thank you to all the speakers and their opening remarks. So now we'll have 4 presentations, then we'll have question and answers. And we are appealing to everyone that if you have any questions, you can put it in the chat. So and we'll follow up during the question and answer session. So not to waste much time, so I'll call the first presentations from Kyrgyzstan. So, and Bakit Mirzaliev will present on the experience of Kyrgyzstan's on the BPaL regimen. Bakit is Ken's CV representative in Kyrgyzstan. Bakit.
Good day, dear colleagues. Thank you very much for this opportunity to present information about experience of Kyrgyzstan with can you see my screen? Guys?
Not yet, Bakit.
Not yet. Sorry, it's share screen. Just a second. Share. Now? Not
see your screen, but you are seeing your calendar.
Yes, yes.
Oh, just a second. Yes. For now.
Yes. Now you can see.
Yes, good. But now it's good. I can deal with it. Thank you very much, guys, for the time. It's a great opportunity to also share experience of Kyrgyzstan, and with support of the Lift TB project funded by TB Alliance in Kyrgyzstan and COICA funding. It is implemented. Screen is a bit. I'll try how to close it. Just a second. This is much better for now, I think. experience of Kyrgyzstan. And what is the first, problem was with implementation of BPaL in Kyrgyzstan, that WHO recommended in operational research conditions, and Kyrgyzstan not have any opportunity to implement it in operational research conditions, because for now in Kyrgyzstan we not have regulations for introduction of treatment or drugs in operational research conditions. That's why Ministry of Health, after rounds of communications and some informative sessions, suggest to use programmatic use of these regimens with operational research conditions. And for now, Kyrgyzstan developed these national guidelines and national protocols, and include their recommended by WHO operational research conditions. And we agreed with our partners, also with Global Fund implemented in Kyrgyzstan by UNDP, that they will procure pretamine for Kyrgyzstan for our operational research. And but procurement time was a bit longer. It's take from 6 to 9 months in case of delivery time and some communication time with UNDP and Global Fund regulations. And at that time, we also communicate with Mylan, which is located in India also, and they have a license to produce this pretamine. And Mylan donate for Kyrgyzstan 50 courses of pretamine for free for operational research use. And also same time, Global Fund, UNDP also continue interventions with the procurement of pretamine, and for now, on the country level, available 130 courses of pretamine. And first enrollments in Kyrgyzstan started in August 2021, and we. For now, we cover all country with implementation of BPaL treatment regimens, and we developed, as I explained before, national guidelines and national protocols. It was all endorsed by Ministry of Health in July 2021. Also, same time we get approval of ethical committee, ARB approval in July 2021. At that time, previously, we prepared the training materials translated in Russian language and local language, and provide facility-based trainings. And for now, we also continue with the on-the-job trainings on regular basis, because physicians changed, also some practitioners in the field changed. In this case, on regular basis, we are knowledge. Recording and reporting forms developed and used for now. Data collection and database, for now, all data collected and in the national database, and same time it is, we use RedCap. It's KNCV database, which is will be used in all countries in parallel. So it is very good for, how to say, compare data. And what is the main interventions in Kyrgyzstan? In accordance with the protocol is a BPaL introduction and implementation on regular DRTB treatment practices and all levels of TB care in Kyrgyzstan. Second one is reduced DRTB treatment duration till 6-9 months with a less number of drugs to 5-7 instead of 20 pills. Increase the treatment success rate of patients with pre-XDR and patients failed of DRTB treatment and intolerant to DRTB treatment. Reduce the number of progression, adverse events, and deaths among DRTB patients and pre-DRTB patients. On this line, you see to now the number of patients screened and enrolled on BPaL treatment regimens. For now, 99 MDR and pre-XDR patients was screened, and 50 patients was enrolled for operational research in operational research conditions. It is different sides of the country also. On the next slide, you see the patients enrollment by month. You see that from August to November, it was in pilot sites in Karabalta city. It was just one site with including the National TB Center. When we just start very carefully enrolled patients with pre-XDR and intolerant MDR-TB patients. But from December, our national partners, NTP, and practitioners in the field also support this idea, and we go to the field, to the South region, and in one visit, in 1 week, we enroll 15 patients to this treatment. And starting from January, Ministry of Health signed the order that all country eligible and all conciliars can enroll patients on this treatment regimen, BPaL. And for now, it is 50 patients enrolled. Resistance to fluoroquinolones among enrolled on BPaL patients. You see that 24 patients was intolerant and failed MDR-TB patients, and 25 patients was pre-XDR, and 1 patient was contact with pre-XDR. Now you see a sputum conversion, and on this slide you see that from 50 patients, 20 patients have sputum conversion after the 1 month of treatment. For now, we're still expecting results for 21 another patients, and but it's a very promising result that after just one month of treatment, around more than 60% have sputum conversion. Treatment results, patient of BPaL. For now, we have results: 19 patients cured, 1 patient treatment completed, 2 patients lost to follow-up, 1 patient during the first month of treatment, we find resistance to bedaquiline and move to individual treatment regimens. 2 patients die. It is not related to the treatment regimens. I will present this information. 1 patient also have results not effective treatment and moved for individual treatment regimens, and 24 patients are still on treatment. On this slide, you see that by data and by days, how many days the patient get treatment, and when these patients, you can see the treatment failed and lost to follow-up. For now, for 26 patients, it is most of them, and we not see the very significant adverse events. Adverse events related just to linezolid, high dosages of linezolid. After the few months of using, they have some neuropathies. I also 1 patient was presented on virtual conciliar. It is DRTB patient with treatment result failed. Bedaquiline not used before. Sensitivity to bedaquiline was confirmed. Enrolled to BPaL treatment regimens in 18 of August 2021. So sorry, it is culture conversion at month 5. Treatment prolonged to 9 months. At month 7 was adverse events, thrombocytopenia, 2nd level, and linezolid dosages reduced to 600 milligrams. At month 8, adverse events like a peripheral neuropathy, and we reduced linezolid dosages to 300 milligrams. During the treatment, patient increased weight to 7 kilos, on 7 kilos. Till month 9, these were 5 negative cultures, and central concilium decision was failed because the big residual changes in the left lung. You see on the slide also the left lung on the X-ray. But our clinicians also suggest to discuss it on the virtual conciliar, on the global level with WHO colleagues, and the Consilia decision was treatment result is cured because treatment on BPaL completed without any things of failure and sufficient number of negative results with consecutive cultures. Because despite all these trainings, despite all these results, some old practitioners still not fully trust for 6 months treatment regimen, and for now still how to say it is not really trust for these regimens, because before they care about patients with 12 drugs in 18, 19, 20 months, and they are not really trust that in 6 months with three drugs is possible to do. That's why it's also some technical partners and need to provide some assistance and support with training. Previously treated second patients was presented on virtual Consilia. It's MDR-TB patients and 4 episodes of treatment without outcomes of lost to with treatment outcomes lost to follow-up 1 time and failed 3 times. This patient didn't get bedaquiline, linezolid previously received, but we confirmed sensitivity to linezolid. Alcohol dependence, periodic prolongation, and drinking. Enrolled on BPaL 24th of November 2021. Conversion by microscopy for 3 months, by culture on month 5. Weight, increased weight for 1 kilo during the treatment. Clinically and other analysis were normal. During the treatment, 2 negative cultures. Also, you see X-rays at the beginning of treatment and after 6 months of treatment. And central Consilia decision was failed because culture on MGIT on month 4 after negative culture on month 3. And we also discussed it with WHO virtual Consilia, and virtual Consilia was made a recommendation to continue treatment till 9 months. Persistent conversion by smear conversion and positive clinical and radiological dynamic allowed to predict the patient's successful result when prolonging BPaL treatment to 9 months. And compliance with the continuing of medication. The delayed onset of conversion is due to the duration of disease, more than 7 years of illness, and the initial prevalence of the extended processes in lungs, which is shown in röntgenologically. Also, some information about the patient.
You have 2 more minutes.
Okay, thank you. Male, 44 years old, previously MDR-TB treatment completed, bedaquiline not received. Episode with DRTB. This is regimen isoniazid, rifampicin, pyrazine, ethionamide, moxifloxacin, stable, taken on BPaL regimen. Alcohol dependence. During the treatment, he showed sign of depression. This patient also was consulted with a psychologist of Red Crescent, and he was depressed, and he have some problems with doctors in health facility, and he lived near the hospital, and at that day he consumed alcohol 2 days, and fought with his wife, with staff, and jumped into the local river and drowned. It was 48 days of treatment. Most days succeed. Second patient's man, 56 years old, has not previously had tuberculosis. This episode MDR-TB with HR resistance was taken on BPaL regimens due to drug intolerance, disturbed by severe epigastric pain. He used bedaquiline, levofloxacin, linezolid, clofazimine, and cycloserine. Alcohol dependence due to alcohol abuse, profuse intestinal bleeding occurred. These patients on 36 days of treatment. Despite the treatment and the reanimation activities, this patient died. What is the results and conclusions? All oblasts and cities, CTTB centers trained on BPaL. Patients are treated in Republican TB Center in Karabalta TB Hospital, TB Center Karasu, Osh Oblast, Jalalabad Oblast, Batken Oblast. It is all sites of country covered by BPaL treatment regimens for now. All patient data is entered into the RedCap database by NCV-KG operator and analyzed by M&E specialist KNCV-KG and NCP coordinators. This data also entered national database. Same time, it's a bit duplication with data entry, but we do it for operational research condition for our own, how to say, interest. And in parallel, the national database also count all these patients. Patients enrollment in operational research conditions completed, 50 patients. Will be under observation in the next 2 years. Follow-up enrollment will be provided under the programmatic conditions in accordance with the WHO recommendations. Collaboration between the national and WHO virtual concilium is very important. BPaL preliminary show very good tolerability of drugs and high culture conversion rates. Important to provide adequate ADSM for timely detection and care of adverse events. Thank you for attention. That's all from my side.
Thank you very much, Bakit, for the interesting presentation. So we'll not waste much time and move to the next presenter, who is Dr. Mamel Kualapio, the PMDT consultant with KNCV and supporting the BPaL operational research in Philippines, Myanmar, and Vietnam. So Mamel will share the country experience of Philippines. Mamel, I'll hand it over to you. You can share your screen. Thank you.
Thank you very much. Thank you, Manza. I'd just like to confirm whether I'm sharing my screen now.
Yes, Mamel, we are seeing your screen.
Thank you. So good day to everyone. Thank you to the organizers of this roundtable discussion for the opportunity to share the experience in the Philippines on the BPaL operational research. So I'd like to acknowledge my colleagues from the KNCV, TB Foundation, the International TB Research Center in Korea, and also our colleagues from TB Alliance. So I'll be talking briefly about the Lift TB initiative and about the BPaL operational research under Lift TB, and spend more time on the experience and preliminary results in the Philippines. So Lift TB stands for leveraging innovation for faster treatment of tuberculosis. And in 2018, Lift TB or TB Alliance collaborated with the International Tuberculosis Research Center in Korea and KNCV in the Netherlands to conduct the BPaL operational research. And this initiative is funded by the Republic of Korea through the Disease Eradication Fund of the Ministry of Foreign Affairs and COICA, as mentioned earlier by Bakit. And this BPaL operational research is implemented in 7 countries. So 4 in Asia. We have 2 from the Western Pacific, Philippines and Vietnam, and 2 from Southeast Asia, Myanmar and Indonesia, and 3 from Central Asia, Kyrgyzstan, Uzbekistan, and Ukraine. So the evidence that was used for the BPaL operational research were based on the clinical trials that involved patients with pre-XDR or XDR-TB, patients who were not XDR but had MDR-TB but with intolerance or non-response to their previous MDR-TB regimen. So the first clinical trial that was used as evidence for this OR was the NICS-TB trial, which used 6 months of bedaquiline, pretomanid, and linezolid given at an initial dose of 1,200 milligrams per day, which was adjustable after a month of this high dose. And the next trial included 109 patients in South Africa. These were patients who were not who had complex cases of MDR-TB. 85% were cavitary, 65% had XDR-TB or pre-XDR-TB, and 51% were people living with HIV. And of all these 109 patients, the favorable outcomes were 90% in that cohort. And not only at end of treatment, but also it showed a sustained cure until 2 months post-treatment with manageable adverse events. This trial was followed by the Xenix trial, which was a follow-on trial to the next TB trial. And this study aimed to find the optimized dose and duration of linezolid. So remember that I mentioned it's given in the next trial, it was given at 1,200 milligrams. So this Xenix trial was done in 4 parallel arms. So as you can see here, and so in this trial, bedaquiline and pretomanid were standardized in all of the arms, but linezolid was randomized. So in the first arm, linezolid was given at 1,200 milligrams for 6 months. So this is 26 weeks. The second arm gave 1,200 milligrams of linezolid for 2 months only, or 9 weeks. Third arm gave linezolid at 600 milligrams for 6 months. And the fourth arm gave linezolid at 600 milligrams for 2 months or 9 weeks. And the total number of patients was 181. As you can see here, the favorable results in all of the arms was quite high. But you can see that it was highest in the first arm that was given 1,200 milligrams for 26 weeks or 6 months, but not bad at all in the group that was given 600 milligrams for 6 months, 91%. Unfavorable outcome was likewise lowest in the 1,200 milligrams given for 6 months, but not bad also in the third arm given 600 milligrams for 6 months. The linezolid dose modification represents the safety aspect of this study, where linezolid was either discontinued or decreased from a high dose of 1,200 milligrams over the course of the treatment. And you can see that the percent or the proportion of patients that had the highest modification for linezolid was found in the first arm with a very high dose of 1,200 milligrams for 6 months. And you can see that it went down as you go through the line. So it was only 13% in the third arm, which was 600 milligrams for 6 months. So I'd like to focus now on the operational research in the Philippines. So this is the map of Philippines, where you see that this OR is being conducted in 12 OR sites. You see here the different regions where the OR site is being implemented at the moment. It was launched in December 2020, and we had our ethics approval in March and our first enrollment in May of 2021. And we are enrolling patients until December of 2022. I'd like to acknowledge our partners in the Philippines, which is, of course, the Department of Health and the principal recipient of the Global Fund, which partly funds the research in the country, which is the Philippine Business for Social Progress, Tropical Disease Foundation, the Lung Center of the Philippines, which is the research arm of the Department of Health, and TB People Philippines. So the objectives of the operational research are to estimate the effectiveness of the BPaL regimen and also the safety of the regimen. So effectiveness does not only mean the end of treatment outcome, but it also means we are looking forward to recurrence-free cure post-treatment on the 6th month and possibly also on the 12th month post-treatment, and also the time to sputum culture conversion. And safety will look at the serious adverse events and also the adverse events of special interest. So there are 3 sets of project indicators that are being measured in this study, and these are indicators for coverage, for safety, and effectiveness. So first on coverage, this is a cascade of care. So from May 2021 to May 2022, there were 1,059 RRTB patients that were detected in the 12 OR sites in the country. And from this number, those that had any of the inclusion criteria were screened. So the inclusion criteria were basically fluoroquinolone resistance, intolerance, or non-response to other MDR-TB regimen. I'd like to say at this point that the fluoroquinolone resistance in the Philippines is quite low. Fortunately, it's only 3 to 4%. So out of this number, 1,059, only 70 were screened. That's around 6 or 7% of this number. And out of the 70 that were screened, 91% or 64 were deemed eligible, meaning they did not have any of the exclusion criteria. And out of the 64 that were eligible, 50 were actually started on treatment, or 78% of the 64. And so I'd like to focus on the 50 later on that were put on treatment. But I'd like first to share the reasons for non-eligibility. So patients who were exposed to bedaquiline for more than 4 weeks by virtue of having been enrolled in another regimen, they were excluded. So there were 2 of those. 2 were underweight, or patients with less than 35 kilos. 1 died prior to enrollment, and in 1 there was no reason cited. And among those eligible, the reasons for non-enrollment were 3 refused treatment because they didn't want to participate in research, or they were too far from the OR site. 3 had a decision from the TB Medical Advisory Committee that these patients might not benefit from BPaL. Some had comorbidities, and others had other reasons. So if we look at the eligibility or the inclusion of these patients, why they were enrolled, in 52% of the 50 patients that were started on treatment, 52% were fluoroquinolone resistant, 42% had intolerance to their previous regimen, and 6% had non-response to the regimen. In terms of demographics, 34% of the 50 were female, the rest were male. If we look at the age distribution, the highest percent belonged to the 47 to 56 year age group, but you can see that majority belong to the economically productive or working age group. 36% of these patients had diabetes and 8% had HIV. Now we look at safety. So for this cohort, there was 24% that did not manifest with adverse events of special interest. But if you look at these bars, peripheral neuropathy had the highest percentage with 52% manifesting with that adverse event. This was followed by 46% with myelosuppression, which was all of them were anemia, and 38% with hepatotoxicity, and a few patients manifesting with QT prolongation. There was only 1 serious adverse event, which was hospitalization, not related to TB, but of a cardiac symptom. Still on safety, of the 50, 54% of patients did not have modification of the linezolid along the course of their treatment. But in 24%, we needed to reduce the dose, and in 20%, there was interruption, temporary interruption, and there was permanent discontinuation. Okay, so now looking at the effectiveness, although these are very few numbers at the moment, the results are very encouraging. So out of the 50 that were enrolled, 18 patients have finished 6 months of treatment, And among these 9 were culture positive at baseline, 7 were smear positive, and 2 were both smear and culture negative. So for purposes of this analysis, we excluded those that were bacteriologically negative and included only the 16 that were either culture or smear positive at baseline. So from these 16, all of them were either cure or treatment completed. So all of them we can say were treatment success. So we did not find any patient that failed, no loss to follow-up, no one died, nor not evaluated. So 44% were cured by culture, 50% cured by smear, and 6% treatment completed. I'd like also to say that at month 2, there was 100% conversion, or all of the patients were smear and culture negative. So beyond the indicators, I'd also like to share what the operational research has done.
Mel, you have 2 minutes more.
Okay, thank you.
Sorry.
And we can see here that it also strengthened the laboratory landscape in the Philippines. So this is Expert MTB XDR, where you see the rapid uptake of Expert MTB XDR that has practically replaced the second line LPA for fluoroquinolone resistance detection. MIGIT is almost available already in the Philippines. It's just undergoing quality control, and genotyping as well on a research basis. I'd like also to say that it has enhanced the research capacity of the Philippines. So this is the research team, the principal investigator, and it has also been strengthening the clinical capacity in the OR sites and also in the TB Medical Advisory Committee, with the ability to identify and manage the adverse events of special interest. It is also establishing a technical resource as we almost move to programmatic implementation. We now have the country protocol that can be used in the guidelines, the clinical guide, an implementation plan, and some job aids that can be used as we move to programmatic implementation. So in summary, I'd like to say that the preliminary results of the BPaL OR in the Philippines show similar success in the NICS and XENIX trials, and all the lessons, strengthened laboratory, research capacity, technical resource, and enhanced clinical practices will pave the way towards smooth transition to programmatic regimen use under the rapid communication. This is my last slide. I'd like to end with this slide, and this is our first BPaL graduate. She is a lady who attempted several times to be treated but never succeeded. She was just discouraged about the sheer length of the treatment and also the daily injectables that she had to endure. So when the BPaL OR was presented to her, she agreed and she said, I really want to get well fast. So BPaL is better for me and I think I can take it. So right now, this patient who used to be oxygen dependent is now cured, and she is now able to do all the most of the activities that she has been doing without the aid of the oxygen. Another patient said, the pills are few. It's not anymore that heavy to take. My body found it easy to take the medicines compared to the past medicines, and there is no vomiting. So this is talking about the pill burden in comparison to the other regimens and also the adverse event. And one said, I'm happy with the results of my treatment and my family is also happy. So all these patients have found not just a cure for themselves, but also a collective sense of commitment to encourage others. So they're now part of an advocacy among patient survivors, speaking about their experience in the BPaL regimen. So with that, I'd like to thank all partners and thank you also for your attention.
Thank you very much, Mamel, for the good information you shared and the experience from Philippines. So for both Mamel and Bakit, so there are some questions already in the chat, and maybe you might start looking at those questions to prepare for the question and answer session. So we'll go to the next presentations, which is the South African experience on the TB practical clinical trial. And this will be presented by Dr. Sherwani Padiashi, who is a research clinician at the TB and HIV Investigative Network, THINK in South Africa. Dr. Shivani. Thank you.
Hi, thank you, Mansa. I just want to confirm that you can see my slide.
Yes, we can see your slide. So maybe you can put it in presentation mode.
Okay, is that better?
Yeah, that's better, yes.
Okay, I'm just going to stop my video for the purposes of the bandwidth. So thank you to the organizers for this platform. Good day, good afternoon, good evening from wherever. I am Dr. Shivani Pidiachi, an investigator on the TB BPaL trial from the TB and HIV Investigative Network in South Africa. I will be presenting the South African experience on the TB BPaL trial on behalf of the Think TB BPaL team, and I have no conflicts of interest to share. I just want to start by sharing a quote from epidemiologist Austin Bradford Hill, who said, "All scientific work is incomplete, whether it be observational or experimental. It is liable to be upset or modified by an advancing knowledge." So I appreciate the opportunity to be amongst the presenters to share and modify knowledge. So a little bit about the TB BPaL trial. The TB BPaL trial is the pragmatic trial for more effective, concise, and less toxic MDR-TB treatment regimens. It is a multi-center, multi-arm, open-label, phase 2/3 non-inferiority randomized control trial. The trial launched in January of 2017 and aimed to find a shorter, safer, more effective treatment for people living with drug-resistant tuberculosis. The trial evaluates the safety and efficacy of 3 new regimens compared to the World Health Organization's standard of care. The TB BPaL trial was conducted in 3 countries, Belarus, Uzbekistan, and South Africa. 7 sites were established, and 4 of these 7 sites were from South Africa. These 4 sites spanned across 2 high TB burden provinces, the Helen Joseph Hospital from the Gauteng province, and 3 sites from the province of KwaZulu-Natal, Doris Goodwin Hospital, King Dinizulu Hospital, and the Think Clinical Trial Unit based in Hillcrest, which was formerly based at the Don Mackenzie Hospital. The trial study design consisted of 2 stages. The first stage, the TB BPaL regimens, included 3 investigational regimens with oral bedaquiline predominant and linezolid backbones. Additionally, 2 of the regimens also included moxifloxacin in arm 1 and clofazimine in arm 2. Treatment was administered under direct observation for 24 weeks in the investigational arms and 36 to 96 weeks in the standard of care arms. Stage 2 aimed to carry forward the arms that yielded the best results from the 3 investigational arms. All 3 arms met the criteria for stage 2. However, arm 1 with moxifloxacin was selected to continue to stage 2. South Africa contributed 205 of the 552 patients randomized. The Think sites contributed 162 of these patients of this trial cohort, and in particularly contributed the large inclusion of people living with HIV, which in itself was important to ensure the generalizability of the study. Randomization stopped early due to clear benefit, and it was demonstrated at 85% of the target, which was achieved in March of 2021. South Africa was one of the first countries to adopt an injectable-free drug-resistant TB regimen. These guidelines were circulated and adopted in South Africa in September of 2018. A short injectable-free regimen of 9 to 11 months was used for RIF-resistant and MDR-TB patients, provided they met specific criteria. Adults and children who did not meet this criteria were given a long injectable-free regimen of 18 to 20 months. Some patients initiated treatment with a short regimen, but were switched to the long regimen once further diagnostic or other investigations became available. Fluoroquinolone-resistant patients were offered a long injectable-free regimen as well, and usually consisted of a regimen including other drugs like bedaquiline. The following quote from my colleague, Dr. Susan Ford, sums up the experiences and emotions of our clinical trial team on the TB BPaL trial. When patients were started on the trial on day 1, they would be assigned to either a new treatment arm or the standard of care arm. It was randomized by a computer program so that at a click of a button, you'd instantly get to see that the patient got the new treatment arm, and it felt like they were winning the lottery. It was really so exciting because you just know how much better it is, and I would give this internal little whoop of joy. You could see the relief and the happiness because they were told they would only need to take 4 different drugs for only 6 months, and they were much less likely to have side effects, which is huge. It makes a massive difference to them. To be able to give our patients hope is honestly the most wonderful, wonderful thing as a doctor. There are many successes and challenges to be shared throughout our experience on the TB BPaL trial. When we reflect on this remarkable journey with our patients, we are able to share these practices which we attribute to our successes. We had a highly skilled team that had experience in both clinical trials and drug-resistant tuberculosis management. We also benefited from a state-of-the-art clinic which patients enjoyed visiting. We relied on teamwork and effective communication throughout our participation on this trial. We relied on establishing rapport between patients, the Department of Health staff, our sponsors, and our monitors to ensure the smooth running on this trial. Our recruitment strategy was dynamic and was adapted to the challenges we faced. From collecting and combing through national laboratory service sputum results to weekly visits to a centralized and decentralized DRTB facilities. We were also able to implement video observed therapy as an adherence strategy. This allowed our patients to take responsibility for their own treatment as an outpatient, and it allowed for remote monitoring, which came in handy during the initial months of movement restrictions imposed by the COVID-19 pandemic. The South African trial challenges. Amongst the challenges, co-managing patients with the South African Department of Health was one of our biggest challenges. Our health system is resource constrained with only a few clinicians managing drug-resistant TB patients. During the first stage of the trial, we required patients to be hospitalized for at least 2 months. This allowed for closer monitoring of the interface and daily in-person dot with our clinical trial team performing this. This put further strain on the state resources and the clinicians responsible for patient drug-resistant TB care. As a result, our trial team had to assist the Department of Health staff in order to facilitate the diagnosis and initiation of drug-resistant treatment in these patients. Weekly meetings with the Department of Health staff were conducted to share results and get feedback on workup of patients. Due to high staff turnover in the Department of Health, we frequently retrained staff on the trial protocol. We nurtured close relationships with the Department of Health staff to try and facilitate trial recruitment. From clinical factors, we had sick patients co-infected with HIV and substance use, particularly alcohol. These patients were closely monitored, adherence checks were done, and we relied heavily on the rapport and communication with the Department of Health staff for co-management. The COVID-19 pandemic further hindered recruitment. and movement restrictions compromised patient follow-up visits. Alternative strategies were discussed with our sponsors and monitors, and telephonic consults were conducted, and video observed therapy was used to monitor patients who could not get to trial site. The KZN province was further affected by civil unrest and flooding. Additional challenges of electricity load shedding impacted on our patient follow-up visits and their travel to site. Relocation of our trial site due to closure of the Don Mackenzie Hospital further resulted in recruitment interruptions. In conclusion, despite these challenges faced during the trial, the 24-week all-oral regimen containing the backbone of betaquilin, protomimid, and hope, with a lower pill burden, shorter duration of treatment, and fewer side effects when compared to the standard of care. I'd like to end by a quote from one of our amazing patients who has completed the trial. Awanda in Globo said, "When you are on treatment, some parts of your life feel like they're put on hold. The trial gave me hope. I couldn't even see the slightest glimpse of recovering from MDR-TB. Here we would like to acknowledge the contribution and collaboration of our sponsors, trial sites, and allied stakeholders, with special acknowledgement of our trial patients." Thank you so much.
Thank you very much, Dr. Sherwani, for the presentation. So we'll now move to the next presentation, which is the TB Alliance experience on the BPaL clinical trial, and also this will be presented by Dr. Frida Sala, the head of medical affairs in TB Alliance. Sala.
Thank you so much, Dr. Mensa, and hi everyone. Glad to be part of this event. My name is Salah Furaida. I work for TB Alliance, and as you know, TB Alliance is a not-for-profit organization, not only dedicated to the discovery or development of TB drugs, but we are also committed to delivery of affordable and accessible TB drugs. And so as mentioned earlier, I mean, TB Alliance developed protomimid and the BPaL regimen. And the idea was to have 3 drugs that all of them, each drug of them. Can you see my screen? And the idea was to develop a regimen that can, each of the 3 drugs can contribute to the efficacy of the regimen. It started with NIX, and in NIX there was few limitations, like it was just in one country, South Africa, using the highest dose of linezolid, 1200 milligram. And however, it was used in very highly resistant TB forms like XDR and pre-XDR using the previous definitions. However, with this high resistant TB, we observed 90% of participants with favorable outcomes, and this was both clinical and bacteriological resolution after 6 months of therapy. Also, we followed all patients in NIX-TB trial for 2 years, or 24 months. And this high efficacy rate of 90% was sustained after 2 years of follow-up. That's why we decided to conduct a follow-on trial, which was ZNIX, to build on the NIX-TB results. The rationale for ZNIX was because we observed high efficacy in NIX, but we also observed high rates of adverse events, specifically peripheral neuropathy, which happened in 80% of patients in NICS, and myelosuppression or anemia, which happened in half of participants in NICS-TB. These two adverse events are associated with linezolid, and we were using the 1200 milligram of linezolid in NICS. So we decided to conduct ZNICS to see if we can maintain the same efficacy of the regimen while we reduce the dose of linezolid to improve safety profiles. So the idea of ZNICS was to investigate 4 different doses and durations of linezolid. So 1200 milligram for 6 months or for 2 months, or half the dose for 6 months and for 2 months. We also expanded the countries. So 4 countries were investigated that were from patients from 4 countries were enrolled in this study, not only South Africa, but also other countries. And the duration of treatment was 6 months. Primary endpoint was 6 months after end of treatment, and then the full evaluation will follow 18 months after end of treatment. Also in XDR, MDR, using the previous definitions, and we also used bedaquiline daily dose in this trial, supported by evidence and publications. And this daily dose allows for fixed dose combination in the future when compared to the 3 times a week dosing. We observed high efficacy in the 4 arms, whether 1200 milligram for 6 months or 2 months, or 600 milligram for 6 months or 2 months. All of them were highly effective. Study was not designed to differentiate between the 4 arms. The time to culture negative was achieved in 6 weeks. That's the median for all arms. And this was the same in NICS TB trial as well, 6 weeks. When we look at the adverse events of special interest, mainly peripheral neuropathy, optic neuritis, and anemia. As you can see here, peripheral neuropathy decreases when you lower the dose of linezolid. All patients, 4 patients who had optic neuritis were in the 1200 milligram dose, usually happens in month 4 or 5, 0 in the other 3 arms, and thankfully all 4 participants were completely resolved when linezolid dose was stopped. And anemia was also mainly driven by the 1200 milligram dose, similar to peripheral neuropathy, and lower in when we use the 600 milligram dose. There was also linezolid dose modifications. Higher, 50% of participants who used the 1200 milligram for 6 months needed to modify this dose, similar to the 1200 milligram for 2 months. And it's way lower when we use the 600 milligram. Still, there is a need sometimes to modify treatment, and modifications could mean anything: reduction, interruption, or discontinuation. So we concluded from ZNICS that it appears that lower doses or shorter durations of linezolid will have the same efficacy with improved safety, and our risk-benefit analysis suggested that the 600 milligram of linezolid for 6 months appears to be the best among these regimens. Actually, this, as just mentioned by my colleague, MSF conducted BPaL to evaluate again the 600 milligram linezolid dose in different BPaL-based regimens, whether with moxi or clofazimine, and this was reviewed by the WHO. As you know, together, ZNICS and BPaL was reviewed by the WHO, and recently we had the WHO rapid communication based on both actually on TB Practical, Xenix, and Nix, was suggested the 600 milligram linezolid dose for 6 months, which will be presented by Dr. Fraser. That was my last slide. Before I end, it's very important to thank, we would not be able to develop Protomanid or the BPaL regimen in TB Alliance without the help of all patients who enrolled in our clinical trials, with help of all investigators and funders, and also the donors, specifically USAID and other donors. So thank you so much, and glad to be here. Thank you.
Thank you very much, Salah. And with the interest of time, I've seen that Bakit and Mamel has already answered some of the questions that are in the chat. Maybe Rakesh, maybe we can take one question for each of the presenters, so then we can move forward with the other presentations so that we can save time. Yes.
I think we have like most of the questions answered in the chat box itself. Maybe anybody wants to raise the hands, like we have the options. We can raise the hand so that we can unmute and do that. So I'm just unmuting Rohit Sarin sir.
Well, thank you. First of all, I'd like to congratulate the team which has conducted this roundtable and on a very important and pertinent issue globally as well as for the country. Yes, we have heard the experiences, though numbers are limited, but the direction is clear. So I think that is something which is very encouraging. I would say that when the Xenix trial has shown the dose reduction to 600 milligram to be effective with the better safety profile, it is not understandable why Philippines chose 1200 milligrams. And in the Philippine trial, most of a large number, I would say, patients did develop signs of peripheral neuropathy or bone marrow suppression, which are probably due to the linezolid. And that may have required dose modification, which was also there in nearly a quarter of their patients. So I would say that going ahead, one should consider the lower dose of linezolid rather than the higher dose. That would definitely be more prudent. Thank you very much for this opportunity, but very well presented and a very timely discussion. Thank you so much, Rakesh, and congratulations to Kuldeep and his entire team and the others for this sharing. Thank you.
Thank you, sir. Mamel, you have your hands raised.
Yeah, I'd like to respond to Rohit for his very relevant question. Yeah, I just like to say that the timelines, you have to understand that the timelines were such that Nix has just finished at the time that the BPaL or the LIFT-TB operational research was launched. So there was a WHO recommendation on the BPaL regimen, including the 1,200 milligram initial dose, and we wanted to keep to that. So at the time that we started with the BPaL operational research, there was no results. There were no results yet of the Xenix trial that found the optimal dose at 600 milligrams given for 6 months. So at that time, the evidence was just for 1,200 milligrams given initially, but adjustable after 4 weeks of the 1,200 milligrams. You can reduce the dose to 600. I just like to say that we are in the process of revising the protocol in response to the rapid communication that was based on the Xenix trial. So we will now revise the linezolid dose to 600 milligrams for all the patients that will be enrolled on BPaL. So thank you very much for your question on that.
Thank you, Mamel. And I'll also urge you to look into the BPaL M regimen, you see, while you are at the research mode, because that also needs further looking into, right? Thank you.
Sure. As we move to programmatic, maybe, yeah. But that is beyond the current operational research, but for sure, we will look into that as well and consider that as one of the regimens. Thank you.
Dr. Neeraja, you want to ask, or all your doubts are clear?
Just a brief question from the experience from Kyrgyzstan. We saw that there were 2 deaths, and I just wanted to know, like, what were the challenges regarding, the care of patient vis-a-vis pre-treatment evaluation and follow-up and the management of ADRs. So it seems that these could be prevented if there was, I may be wrong in that, but I just want to know the challenges that were there in the field regarding this.
Yes, thank you very much, Dr. Naira. It's of course, it's for now, in case of our patients who die during the treatment, it was I would say some conciliar decision, not really conciliar decision. It's a причинно-следственная связь. It's how to call it. It's we made investigation for both two cases. It was not related to the drugs and treatment regimens, but time to time also it's happened in general healthcare system and also in TB service. And of course, if the daily based better management at adverse events like alcohol abusers and psychological consultation and better, how to say, daily based, but it was not enough. We provide a daily based consultation with psychologists, but despite all these efforts, these patients, how to say, in case of the stress with the family, with because the first one, after they using alcohol, he jumped to the river. It's sometimes it's happened. But if at that time the doctors will be around and provide a better consultation, it's of course it's possibly that we can stop them at that stage. Also, the second patient who also use alcohol at that time and long term, and of course we try to how to say solve this issue, and also despite all our efforts and local doctors' efforts, this patient continue using the alcohol, and this bleeding was happened, and we can also, despite the reanimation how to say activities, we cannot save these patients. And if we provide as conclusion that if the healthcare system and all partners provide the better management, it's of course we can reduce number of deaths during the treatment. But the conciliar decision was that it was not related to the treatment by drugs, betaquilin, pretamanid, and linezolid. It is how to say, it is related to how to say regular general management of these patients, and we agree that if we will better care about on daily basis, care about these patients, we can keep them and prevent them this death, of course.
Thank you, Vikit. That was good. Thank you so much.
Thank you.
There is a question from Dr. Vikas Oswal to Mamel in the chat box. Request to reply that in the chat box itself. Also, there is a question from Dr. Preeti, JJ Hospital. So that's again an individual question. We can reply in the chat box itself. So I think Dr. Mansa, we will move to the next session. So we have two more very important sessions, one by Dr. Fraser and second by Dr. Malik Parmar from India. So let's move to that sessions. Over to Dr. Mansa.
Yeah, thank you, Rakesh. So we can move to the next presentation, and Dr. Fraser Weyers, who is a senior consultant at KNCB, will talk about the WHO rapid communication. So the key changes to the treatment of drug-resistant tuberculosis and the transition from operational research to implementations of BPaL containing regimens on programmatic implementation. So Dr. Fraser. Fraser, we are not hearing you.
Yeah, I hope now that kind of you've unmuted me.
Oh yeah, so now okay, we're hearing you now.
Can you see the screen as well?
Yes, we can see the screen.
Right, the presentation, great. And thanks very much for the invitation. And
Fraser, can you put it on presentation mode?
Right, this is where it always goes wrong.
Mm-hmm.
Is that better? Because when I put it on presentation, it seems to be lost. Can people see the presentation?
Yeah, we can see the presentation.
Yeah, if I put it in presentation mode, it disappears.
Go back to presentation mode and then click, there's a button you can click to make it appear properly. You go back. Oh.
Now we've lost it completely.
Yeah, just share screen again.
Oh, isn't technology wonderful?
Maybe somebody else can share for you, Fraser.
Maybe Fraser, you can send it to me, then I'll share it if anything.
Yeah, I think I sent it to you last night. Do you see it now?
Yeah, we can see it.
Yeah, I think I'll leave it at that if that's okay.
Yeah.
Oops, I'll just try and zoom a bit. Yeah, anyway, thanks. This is basically what I would like to do is just quickly remind people of what is in the WHO rapid communication. And then based on our experiences from implementing new drugs and regimens in countries, under a different range of projects, just lay out a sort of package that we've drawn up for how to move from operational research to programmatic implementation of BPaL containing regimens. So thank you again, and good morning, good afternoon, good evening to everybody. Namaskar to all the colleagues in India. Hang on, sorry, Agnes, I've tried clicking presentation and it goes a bit wonky. So I hope I can just do it this way and people will see. I say the information in the rapid communication really should be known to everybody, hopefully. Just to recap, the latest WHO guidelines are from June 2020, but in the intervening period, there was new data available. This was mainly from the Xenix and the TB practical trials and the next trial and programmatic implementation by the NTP in South Africa. So with this new information, WHO convened an independent guideline group in February, March this year to assess the results of the analysis of the new data. And then in May, they released the rapid communication. I think the important part is actually the first statement, which I've highlighted some of the points in yellow. So we are now talking about all patients with MDR or RIF resistance, not just the pre-XDR and failures of MDR treatment or intolerance to MDR treatment. This is moving further forwards in the cascade of patients. So it includes those with additional resistance to quinolones. They all can benefit from all oral treatment regimens and implemented under programmatic conditions. That is a major shift as well, moving away from the use of BPaL-based regimens under operational research conditions only. So I have the recommendation will be, I have that 6-month all-oral BPaL-M regimen can now be used programmatically in place of the 9-month or longer regimens in patients aged over 15 with MDR or RIF-resistant TB who have not had previous exposure to bedaquiline, pretomanid, and linezolid, and this is defined as 1-month exposure. But as we've been having a discussion, even patients who have had exposure, could be included, but you need DST. Obviously, the next step is that if you have DST, documented DST of quinolone resistance, the recommendation is just to give them BPaL. So now we are looking at BPaL-based regimens being able to be used under programmatic conditions for rifampicin-resistant patients, the vast majority of multi-drug resistant TB patients, and the vast majority of pre-XDR TB patients. DST to quinolones are strongly encouraged, but it shouldn't delay treatment initiation. However, as was raised by a colleague, Dr. Roy, I think personally, as WHO recommends DST to all the new drugs every time they update, I think it is beholden that the DST capacity should be available. And this would be to quinolones, bedaquiline, and linezolid. And I would say delaminid, but I'm trying to seek laboratory expert advice on this, whether that will be good enough as a surrogate for pretomanid DST whilst that is being validated and implemented. From South Africa's data, there was also an alternative 9-month all-oral bedaquiline containing regimen. This is preferred over the longer regimen in adults and children with MDR and RIF without previous exposure, without quinolone resistance, without extensive disease or severe extrapulmonary disease. Here, the recommendation will be that quinolone DST is mandatory before you can start this regimen, and there are alternative dosing and drug use within the first month. So you could replace the 4 months of ethionamide with 2 months of linezolid. However, I know this has, I think, many downsides compared to the use of the 6-month BPaL-based regimens. However, I have patients who have XDR as now defined by WHO, and those who are not eligible or have failed shorter regimens, they may have to be used, treated with an individualized longer regimen. And that is designed using the WHO priority grouping of medicines. And underneath it, which is important, that actually just to remind people that this all needs to be given under good clinical practice. So patient-centered care and support, maybe informed consent where necessary, but now if it's programmatic, that may not be necessary. ADSM, as has been raised by many of the colleagues, is a crucial factor in this. And there has to be regular monitoring of patients and of drug resistance as we go along. Some key safety findings, and Dr. Sala has mentioned some of them, and linezolid dosing, I have now, I know the optimal dose is defined as 600 milligrams of linezolid daily from day 1 of treatment, preferably to be continued throughout the 6 or 9 months. Also, the concern about pretominid and male reproductive health, that one now is largely alleviated on the basis of new data. So this one does not really need to be considered. So the basic takeaway message, kind of everything, is that WHO shows that BPaL-based regimens can be safely administered, and they are very effective for the vast majority of drug-resistant patients. So how do we move onwards? I say, this is what KNCV has sort of packaged together based on its experience and lessons kind of learned during the support of countries introduce new drugs and regimens under the Challenge TB project. This was 2015, 2019, and this was the introduction of bedaquiline, delamanid, and the older injection-based shorter treatment regimen. And then from 2019 onwards, we have been involved with BPaL operational research in 7 countries. And there have been a number of other projects under TB Reach Wave 7 and direct KNCV funding. Obviously, this is a sort of generic package, and it needs to be adapted to specific country settings. So some of it may be relevant, some of it may not. So obviously, for those countries that are doing BPaL-related operational research, WHO is urging people not just to stop it, but to complete it. So you hear that Kyrgyzstan have enrolled their 50 patients into their operational research cohort. Philippines will continue and hopefully enroll 100 by the end of the year. Obviously, then those patients have to be treated and taken through to completion of treatment. If possible, they should then also be followed up post-treatment, minimum 6 months, hopefully 12 months. The data collection needs to be completed, cleansed, validated, and analyzed. And then finally, the experiences and results written up and disseminated. But some countries, if they do not have ongoing BPaL related operational research, they don't really need to consider those 4 ones, but go straight into the transition from whatever they have as standard of care now to the BPaL containing regimens. Something we have learned as we have gone along, and I think Bakit mentioned this, that advocacy is crucial. That it is amazing that every time new science and evidence is presented, you then need to really convince people at the country level that this is correct and it works, and we know a lot about it. Obviously, some countries like to have their own evidence in their own countries first. But advocacy really is a crucial step to get buy-in at all levels. So obviously, the rapid communication hopefully is now fully disseminated to people. Guidelines and operational handbook, we understand from WHO they are expected to release them in the last quarter of this year. But those are just the documents. There has to be then awareness raising amongst all the stakeholders, technical working groups, treatment committees, patient support groups, and professional societies. The last one you hear from by Kate, that even after all the efforts, and also Mamel, I think, expressed it, that clinicians are not yet convinced totally about this regimen. A lot of advocacy and awareness raising is going to be needed. Then obviously the regulatory status of particularly pretominid, it varies in different countries. In some countries, it is registered. I'm sure Salma can say how many, I just can't remember. but obviously kind of there has to be a mechanism of getting predominant into the countries, especially those countries where there is not registration of the drug as yet. Then you need to do the planning. And kind of obviously, really, you need a fully costed introduction and rollout plan. And kind of you need to get the money and kind of to procure the drugs, to do all the preparatory status kind of activities and have the trainings and then implement. And just like with any new drug or anything, there has to be rapid and frequent forecasting. Obviously, this is going to include a phase out of your old drugs and regimens and a phase in of new regimens. I have now, obviously, for a country as huge as India, this is a complex activity which needs a lot of input and planning and forecasting. Obviously, behind it, I have your national guidelines need to be updated, and kind of job aids. Mamel showed a number of examples from the Philippines. Obviously, people do need little reminders of things, especially when they change. There will be a need for a training plan, but obviously you will need to update all the material and the curriculum that you have. But then I have you need to do kind of national or state level TOTs, and then do the usual cascade training downwards. Something that also is a crucial bit and often is forgotten, as has been sort of raised by Blessy during the webinar, and have the engagement of community groups, patient organizations, civil society organizations is crucial. And as I was saying at the beginning, advocacy is crucial, but it's not just within the health services. It is going to be crucial that that information is going to be shared and taken on board by the community and the patients themselves. Obviously, then once you've chosen your initial sites, they need to be assessed in the sense of what clinical and laboratory and human resources and information systems are available. Do they need upgrading, etc. Then I was saying that needs to be staff training, both at the national and the initial implementation sites. And you may need to adapt your respective national information system to include BPaL and BPaL-M. Obviously, for the Indian colleagues, this is back to Nikshay. How does this fit in? And then really there is the usual activity that goes to any regimen is regular supervision, monitoring and mentoring of the initial implementation sites. And then obviously scale up until national coverage is achieved. Now, I know obviously for Kyrgyzstan, which remind me by Kate, I think is population of 5 million. That last one is going to be on a different level to scaling up, say in India, to 1.2 billion population. And just lastly, really many thanks to all the patients, the NTP staff, the partners and the donors and KNCV colleagues for everything that we've achieved over the last 7 years together. Trying to ensure that as many DRTB patients as possible receive the best treatment and care that's available. Thank you for attention, and I'll switch back to the chat line to see questions.
Thank you very much, Fraser, for the presentation. So, and we'll move to the next presentation, which is India's vision on the BPaL, and this will be presented by Dr. Malik Parmar, who is a National Professional Officer for WHO India. Dr. Malik, the floor is yours. Thank you.
Thank you very much. I hope I'm audible. Can somebody please confirm?
Yes, Dr. Malik.
Yeah, you're audible. Yeah.
Right. Thank you. First of all, for all those who do not know me, I am Dr. Malik Parmar. I am the focal person for drug-resistant TB for the past 8 years and for TB preventive treatment for the past 2 years. The WHO Country Office for India is strategically positioned that it is embedded within the National TB Elimination Program. We sit together, work together on a day-to-day basis. And it has been a privilege over the last 8 years to have been able to kind of see these transitions from research. I mean, first of all, getting into operational research mode and then transitioning to programmatic scale up, whether it is the initial bedaquiline conditional access program that we had in 2016, then the delaminid one in 2018, and now we are looking at BPaL. I do not have a presentation given the fact that we have just 10 minutes allotted to this, so I would speak instead. So the topic given to me is the vision, So the vision of India, it was announced by our Honorable Prime Minister in 2018 that India would like to achieve the Sustainable Development Goal targets of 2030 by 2025. The urgency is there, and what you need is to rapidly scale up and introduce and scale up these newer tools. BPaL is not exempt from those tools. So BPaL, BPaL-M, the dialogue has been going on for advocacy in India since I would say 2018, 2019, when the TB Alliance team, started coming in and advocating alongside with us, with the Ministry of Health and Family Welfare officials and all, as well as with the national experts. And then in 2020, when the WHO guidelines kind of spelled out the role of BPaL and recommended countries to kind of, introduce this under operational research conditions. There is a process that we have in India that we have a national technical expert group, a committee of very esteemed and very experienced doctors who sit together, review all the evidences, and then take a concerted call for guiding or recommending technical suggestions to India to move forward. So our role is basically, as WHO does, put across all the evidences on the table, consolidate and bring in all who have experience to kind of, talk about their research, so that there is, clear evidence on the table for discussion. There are, then experiences being shared by local experts. So in 2020, a very, clear decision was taken in consultation, of course, with the National TB Elimination Program, that India would, rather than getting into an operational research mode, would go into a pragmatic clinical trial. I wish that sometime we have the lead of this, study, which is called the Modified BPaL study. Dr. Padma Priya, she's already on the line to kind of, present at some stage whenever it is a suitable time. But yes, there are about 7 sites in India where BPaL was introduced as part of the study, and enrollments are going on. So talking about our vision, the vision is to kind of move to scale sometime in 2023, that is next year. Now, how would that happen? The transition, I mean, I must thank Fraser here for having spelled out those 16, 17 steps. Most of the steps are going on in parallel here in India. And under guidance of the National Technical Expert Group, a subcommittee has been now appointed to kind of, look into each of these steps, starting with a national document, a guidance document to kind of, take this forward. So yes, work is in progress on transitioning from research to actual programmatic rollout. And it would not happen, in one flash. It's a phasing in process, which we have experienced way back in 2016 to 2018 for bedaquiline, as well as for delaminid. And right now, while we simultaneously support the National Institute for Research in Tuberculosis to complete the operational or the pragmatic clinical trial, the enrollments within the next, say, few months' time, so that we have the opportunity to have the interim results also in parallel while we have the national guidance document being coined to kind of, have a simultaneous look at what refinements are required based on the local learnings on using BPaL under the programmatic setting through that pragmatic clinical trial in Indian setups. Plus, I must thank all the presenters from various countries and the organizations to have shared this particular, to have, shared their experiences in this particular forum. This will definitely help, encourage and, give confidence to the audience from India here to start preparing their mindset to transition towards these new standards of care recommended by WHO for programmatic implementation. Simultaneously, the system readiness, many points which Fraser mentioned apart from the national guidance document were the system readiness and engaging all stakeholders. So in parallel, there is also efforts, within the Central TB division, the departments of laboratories, treatments, the procurement team, the pediatric team, they are all kind of internally coordinating, and those preparations are already going on to kind of, make sure that everyone is onboarded. At the same time, there is, already a sign of uptake or kind of buy-in, I would say, as Fraser mentioned, from the national experts. But the guidance is to go in a phased kind of approach so that we learn from the initial kind of sites and initial experience. And this subcommittee, which has been formed, will also be looking at the efficacy and safety monitoring aspects periodically, so that we have a kind of informed approach to kind of move towards scale up, and also have the ability or opportunity to simultaneously refine the national guidance. Systems for bringing in Pretomaned in the country, systems for community engagement, for advocacy with the private sector, the standards of TB care in India, a document which is primarily used to kind of, promote quality care in the private sector. This particular component is also being simultaneously embedded into the standards of TB care, which is under revision, so that the patient seeking care in the private sector and the private network of doctors that we have across the country also kind of, get this sense that, okay, in India, this is what is, the country is headed towards having BPaL-M as a standard of care in the months or a few, quarters to come. So that's how the preparations are on, and the vision is to kind of, have the transition completed sometime in 2023. I would also like to, before closing, thank Dr. Sachdeva for having organized this particular, event, and bringing all the global experts and the experiences from across the board on this. And the vision is also to kind of, leverage on the presence of so many partner agencies and organizations to kind of, come together and contribute to address the implementation challenges as we move forward, along with the Central TB division, to help them make this vision come true of having BPaL in the country sometime, fully available as a standard of care in 2023. Thank you so much for this opportunity.
Thank you, Dr. for this sharing the vision of India in moving forward with BPaL regimen. It's time for discussion based on last two presentations. We can have a discussion. If there are any points to discuss, please raise the hand so that we can unmute, so that we can have a discussion now. Could see Dr. Padma here, the NIRT director. Dr. Padma, you want to yeah, Dr. Neeraja has raised her hands. Yeah, Dr. Neeraja.
So, Dr. Parmar, two brief questions. How long would it take for regulatory approvals to be made available for launching it in the program? I'm sorry if I missed it. And secondly, what would be the pathway for making this regimen available to the private sector as well? The TB specialists in the private sector to start treating their patients with the modified or otherwise BPaL regimen. Please, over to you.
Right. Thank you so much, Nirja. The first question about the regulatory approvals. So the current regulatory approval, which is in place, is for providing pretomanid as a component of BPaL regimen for treatment of MDR-TB patients, with the condition that the drugs would be available through NTEP mechanisms, right? And the conditionality of having a phase 4 clinical trial is being fulfilled by the effort being made under the leadership of Dr. Padma Priya at NIRT Chennai. So that is the condition, which brings us to the second question that, okay, if it has to be done only through the NTEP mechanisms, then how would the private sector get access to this? So this has been a case scenario. It's not a new thing. Okay, it was there since the time bedaquiline was introduced with a similar condition from the regulatory authority that the access should be made available only through the public sector. So for that, in the subsequent versions of the national guidelines, in consultation, of course, with the experts group at the private sector engagement, as well as some of the key players who were interested to join the program, a mechanism of a memorandum of understanding has been established for some hospitals who can become hub hospitals, and the network of private doctors who are, routinely, there is an established ecosystem of a referral network between standalone private clinic and a major hospital. That kind of existing network is being leveraged through the PPSA mechanism, as we call it, as the patient provider support agency mechanisms. These were all piloted in the year 2014 to 2016, and we had seen significant, difference in the uptake and engagement of the private sector. The same things are being applied here now to develop a hub and spoke model. So we, as on today, have about 21 drug-resistant TB centers across India, which are in private hospitals, and their network of doctors are able to kind of, access this through that private hospital, a bedaquiline or a delamanid containing regimen. And BPaL also will go in that same direction through the same mechanism. And efforts are also being made to kind of, scale this up now to have at least in every major city, 1 or 2 such private hospitals identified and engaged under an MOU, both from the public sector as well as through the PPSA mechanisms, as well as through partner projects. There is a project with one of the partners who have taken up 4 states and about 10 centers in the private hospitals to be, converted into or engaged as drug-resistant TB treatment centers. But in places where private hospital hubs are not there, the standalone clinics can still, link up with the nearest drug-resistant TB centers. In India, we have something like 735 drug-resistant TB centers spread across, practically every district is covered except for very small districts, which are linked to the nearby district. So that opportunity is there, but the bridging of this, and the awareness of the private sector, through the IMA mechanisms and the PPSA mechanisms and all is something which is an effort ongoing. There is one more, workshop on Monday, Tuesday, where we are, going to be having this national task force meeting for technical support units for private sector engagement. And that's where the dialogue on how these private hospitals can be encouraged to come forward is being thought through. So these were the 2 responses to your question. I believe I saw a comment from Blessina. Blessy, thank you so much for that important comment. The subcommittee does not have any person affected with TB. However, the list of reviewers for the national document that has been developed does have it. So there will be, consultations that we are requesting the Central TB Division, that all these key stakeholders who have a bearing on shaping up the national guidelines be kind of, engaged at a stage before we go forward. So that's about it. Back to you, Rakesh.
Yeah, thanks. Blessy Kumar, do you have further comment?
Yes, I would like to mention that, I would really like to see this make a difference in the lives of patients in India. We've seen encouraging results already presented. We've had the results of the practical study, the next study. So I'm, very happy to see the progress in other countries, and we would like to support this to be implemented in India as well. But aside from that, like I mentioned in the chat, I think it's really a missed opportunity that we are sitting here, 260 people were there in the beginning, that we did not have the opportunity of giving a 2-minute slot for someone who has gone through this treatment to share the experiences. We've seen their photographs. Everybody has quoted them. But why is it that we do not think it is important to have a person, share their voice as well? I think I would like the organizers to kindly take this as a serious note, because in India, we have the highest level commitment to community engagement. And if we are not following it, then we are actually doing something wrong. I was very encouraged when I heard about the community engagement program in the Philippines, and would like to congratulate Mamal for that. And we keep getting regular updates for them. And even Bakit, even though he didn't talk about it now, he's talked about it before in some of our webinars. So I think in India, Malik, also requesting you and Padma Priya and others on this to consider community advisory boards. There are enough research literate TB affected people, TB survivors in India. Not everyone, like you think, is uneducated or illiterate. There are people who have experience of TB who can sit across the table from you and discuss and deliberate. Please consider community advisory boards. This can be a real game changer. And this is my humble request to you. Please make a note that this is a missed opportunity, and that going ahead from now, that we will really take this seriously, the whole community engagement component. Thank you very much.
Yeah, thanks, Blessy. That's noted, and we'll note for future actions. Yes, Dr. Vikas Oswal.
Yeah, thanks a lot for the opportunity. First of all, I'd like to congratulate everyone for such a fantastic presentation. This question would be for all the presenters over here. Would like to know if by any chance you have or any of you all have used this BPaL other than the OR studies, other than the operational research mode. For example, if there is a patient who has already been exposed to bedaquiline or been exposed to linezolid, and if you have by any chance done a DST which is showing as sensitive, whether will you like to still give BPaL to the patients who have already taken second line drugs and still the failures before proceeding towards the just a palliative care? So just want to know the experiences in their own countries, if they have used by any chance.
Yes, please.
I can give you the kind of advice that we have given, and then hand it over to kind of the country level people to kind of give evidence on the ground. And kind of what we've said is that if you have been treated with a previous MDR regimen that contains bedaquiline, linezolid, and delamanid, if you have had less than 4 weeks of treatment, those patients are eligible for BPaL. However, obviously, you should do DST for bedaquiline, linezolid, and delamanid at the start of treatment, and see. For those patients who have had more than 4 weeks, what we are advising is that they have DST immediately done for bedaquiline, linezolid, delamanid, if susceptibility is demonstrated, then they could be eligible for BPaL, or they could be given a longer individualized regimen based on DST and the WHO design. Now, whether any of the countries have kind of that type of information, I'm not sure. We are just beginning to bring data in from the different countries. I say the different countries are in very different stages of implementation of the OR, but all our activities are under operational research, apart from maybe a little bit in Kyrgyzstan after they have enrolled the 50 patients. But I'll hand over to Kate for that.
So Shirvani.
Thanks, everyone. I just want to make a comment on the bedaquiline past use. As we've been using the regimen under clinical trial settings, some of our patients had started with the standard of care within the Department of Health, but we followed the procedure of less than a month of treatment exposure. And in South Africa, our country has had access to some of these drugs since around 2017, and we know that there are patients that are resistant to newer drugs like bedaquiline, and that's concerning to us. And we often ask for extended drug sensitivity testings to actually check what drugs they're actually susceptible for these regimens. So we use that as our measure of direction. But of course, as new results come through, it'll be interesting to see how it's going to be used. We also use repurposed drugs, and these patients often end up getting a longer regimen with drugs like delamanid as well. So yeah, those are the little gems from South Africa, but I'd be interested to know what's happening in the other countries. Thanks.
Thanks for all the discussions. We have Dr. Ravinder Kumar with us, the TB specialist from the Central TB Division. Sir, over to you for your remarks.
Thank you, Dr. Rakesh, and good afternoon, good evening, and good morning to all the participants from different parts of the globe. So at the outset, I would like to thank Dr. Sachdeva and Union team and KNCV for organizing this very important roundtable discussion on DRTB management. We had a very good discussion during and very good presentation from different countries like Kyrgyzstan, Philippines, experience from South Africa. So globally, we required a shorter oral safer DRTB regimen for our patient. It is a need of ours. So after release of WHO rapid communication, countries already preparing for the implementation of these regimen, and BPaL is going to be a standard of TB care in India by 2023. We are planning a phase-wise implementation of BPaL regimen in the country. For this, internal consultation is already going on, and we already have a dedicated group that is called National Technical Expert Group for reviewing all the global evidence, so that how we can start implementation of these regimen in our country. For this, we are also seeking support from all our valuable partners interested in the field, so that they can help us in overcoming the challenges which are going to face by the program division in the future. So we also have a very good recording and reporting system, which is called as Nexus system. So we have already made a necessary adaptation for the recording and reporting of these regimen in the future. So once again, I thank the organizer and all the participants for participating for this very important discussion. Thank you very much.
Thank you, sir, for this remarks. Now I request Dr. Manu Matthew, the Deputy Project Director of IDFI-TB project, for formal vote of thanks.
Thank you, Rakesh. On behalf of the IDFI-TB project, KNCV and the union, we thank all the participants and expert speakers from KNCV, TB Alliance, Think TB, and WHO for their discussion and comments. Special thanks to USAID and the Central TB Division for enabling us to conduct this webinar. Hope this roundtable has been informative. Till the next session, thank you, everyone. Bye.
Thank you so much. We will meet again next month. Bye.